Good morning, and I bring you greetings from the cleanest hospital of cleanest city to the cleanest capital of country. Once again, thank you so much, Dr. Sanjay and Team GastroCare for having me here. So in next 12 minutes, what I will be discussing is how to approach an abdominal lymphadenopathy. Next slide, please. So you all know lymphadenopathy is a benign or a malignant enlargement of lymph nodes situated in the abdomen. And the other etiologies other than malignancies and infection can be autoimmune disorders, medications, iatrogenic causes. And except abdomen and chest, most of the lymphadenopathy can be diagnosed simply on a history and clinical examination. Next slide, please. So what is so special about abdominal lymphadenopathy? Because these lymph nodes cannot be palpated. They just are incidentally detected on an imaging, and most of the time they can be diagnosed on an ultrasound, but sometimes you require CT, MRI or PET to diagnose them. And they usually indicate some of the chronic problems like infections like tuberculosis, cancers, lymphomas, and some of the autoimmune diseases like Crohn's disease. So how do we approach them? And the first and foremost thing about approaching them is to understand which group of these lymph nodes are. So these are the group of lymph nodes which you can see in the abdomen, starting from retrocrural, retroperitoneal, gastrohepatic, portahepatic, celiac, along superior mesenteric artery, pancreatoduodenal, perisplenic, mesenteric, and lastly pelvic lymph nodes. So these lymph nodes are significant or insignificant is decided by the size and shape. So if it is a retrocrural lymph node, if it is more than 6 millimeter in short axis, it is significant. While if a pelvic node, it is more than 15 millimeter, then it is significant. And again, you have to decide whether it is a generalized or a localized lymphadenopathy. So this is what is a mesenteric. This is most often we see in our day-to-day practice that we go for any cause, USG abdomen, for a pain in abdomen, for an abdominal discomfort, and sonologists report mesenteric adenitis or lymph node along the mesentery. So most of these lymph nodes are less than 5 millimeter. When they are greater than 5 millimeter in short axis, we call them significant. And being an incidental finding, patients most often become curious about these lymph nodes. So normal sized lymph nodes are these are routine lymph nodes. If they are less than 5 millimeter, they should be ignored. They are usually seen in children, especially after an episode of fever or an episode of pain in abdomen. A recent study showed that a threshold of more than 5 millimeter with an enlarged mesenteric lymph node are leading to a high positive rate of 54%. And therefore in children they have come out that unless they are more than 8 millimeter, they should not be called a significant mesenteric lymph node. So in children, more than 8 millimeter is significant, while in adult it is more than 5 millimeter, then it is significant. Therefore, sonographic detection of a lymph node should also include this shape, oval, elongated, and if they are more than 8 millimeter, then only they should be cut. And they should be considered a normal finding unless you have other things to diagnose. However, it is not only the size, there are other things. So the number, the distribution, they are also important. And the causes for these important etiologies leading to mesenteric lymph nodes are enumerated here. And most important are hematologic, metastatic, and some of these immunological diseases. Infectious diseases included viral, tuberculosis, parasitic, and some of these lipid storage diseases in children can lead to these mesenteric lymphadenitis. So what are the symptoms of abdominal lymphadenopathy? Most common about are tenderness or pain, most often in the right lower quadrant, fever, a feeling of illness, loss of appetite, fatigue, lack of energy. So all the symptoms of abdominal lymphadenopathy are very vague. So one and the most important thing about any lymph node is whether they are malignant or not. So you have to look at the patient and you have to see whether this patient is in high risk case for a malignant lymph node. And the risk factors for malignant lymph node, if patient is more than 40 years of age, There is a generalized lymphadenopathy. Lymphadenopathy is persisting despite treatment after 6 weeks. Male sex, node not regressing after the treatment for about 8 to 12 weeks. If the node are associated with supraclavicular lymph node and if patient has significant systemic signs. So conventional and abdominal ultrasound remains the first investigation. CT is the primary modality to confirm these abdominal lymphadenopathy. An optimal technique for CT is a contrast enhanced CT to diagnose and to define these lymph nodes. Some of these benign lymph nodes can sometimes appear like malignant lymphadenopathy, and knowledge of the various nodal chains is very important to decide whether it is a benign or a malignant or other causes. So these are the features which you can differentiate. So all the imaging technology, if you put together ultrasound, CT, MR, PET, the sensitivity and specificity ranges from 50 to 90% depending on the operator and depending on the technique. But there is no imaging modality which can accurately diagnose just on one basis that this patient has this disease leading to these income. So how to suspect benign versus malignant? These are the features. The best feature is if lymph node has a preserved hilum, unless proved otherwise it is going to be benign, and if the lymph node hilum is lost, unless proved otherwise it is malignant. Secondly, the diameter. If the long axis to short axis ratio is more than 2, it is likely to be benign. If the ratio is less than 2, it is likely to be malignant. Recently, those contrast enhanced ultrasound has taken over, and they are the technique by which you can evaluate the tissue perfusion of these lymph nodes. And if you have a vascular tumor, vascular lymph node, chances are that this is going to be a malignant. Higher sensitivity in identifying the minor regions of hypovascularity or hypervascularity, and Doppler techniques have led to the characterization of these lymph nodes. Compared with other imaging modalities, grayscale US combined with contrast enhanced ultrasound is capable of evaluating shape, margins, internal structure, and vascularization of lymph node, which will differentiate between malignant and benign. And it has improved the accuracy of ultrasonography for the diagnosis of lymph nodes as compared to the conventional ultrasound. Another important technique which has been added in ultrasound is elastography, by which you can look at the stiffness of the lymph node. More the stiffer lymph node, chances of it being malignant are more as compared to the softer lymph node, which are less likely to be malignant. The MDCT has a great role in characterization of lymph nodes. They differentiate between normal and pathologic lymph nodes, and the criteria are again morphology, distribution, and enhancement pattern. It is recommended whenever possible, MDCT examination should be performed prior to any nodal biopsy procedure in these patients who have incidentally detected lymph nodes. The workup to confirm the diagnosis is biopsy, and these biopsies can be fine needle aspiration, core needle biopsy, or EUS guided or ultrasound guided biopsies, are then lastly the open excision biopsy. Here comes the role of endoscopic ultrasound. It is the most important tool to evaluate the abdominal lymph node. Principle of the ultrasound is same. Resolution of lymph nodes are better in endoscopic ultrasound as compared to CT. To identify which suspicious lymph node should be accessed for the biopsy is better evaluated on an endoscopic ultrasound, and endoscopic ultrasound guided tissue acquisition has been increasingly used to diagnose these lymphadenopathies, and these characterize the patient's subsequent management. So this is the picture of an endoscopic ultrasound showing a periportal lymph node, and the next video shows that the periportal lymph node biopsy, same time you can do a lymph node aspiration as well as biopsy. Fine needle biopsy has undergone an impressive development with quick and reliable histopathological diagnosis. You have all seen yesterday how an aspiration was done and a diagnosis was made in the next few minutes. Therapies are currently available, so tissue acquisition of malignant lymph node is a mandatory thing to identify the tumor biology, and fine needle aspiration and biopsy needle are able to guarantee accurate results and with perfect specificity and suboptimal sensitivity. Criteria based on B mode evaluation and Doppler features fail to adequately characterize the high specificity of lymph node nature. So nowadays, use of EUS image enhancement technique like Doppler, real-time elastography and contrast-enhanced elastography has improved the diagnostic value of endoscopic ultrasound in the evaluation of these lymphadenopathies. And these are the criteria to differentiate between benign and malignant. If the on a US and if the lymph node is oval, chances are benign, round is malignant, irregular shape is benign, clear-cut asymmetric is malignant, ecostructure is heterogeneous, benign, homogeneous is malignant. So by these features, and obviously by Doppler and subcapsular vessels, whether they are present or absent, you can differentiate between benign and malignant. This is just to reiterate that some of the drugs can also lead to the lymphadenopathy, and we should not unnecessarily investigate these patients if these patients are taking these drugs for a long time. So ladies and gentlemen, I would like to summarize that lymph node characterization represent a crucial point for the diagnosis of patients coming with abdominal lymphadenopathy. With the addition of new technologies like contrast-enhanced ultrasound, elastography, in transabdominal ultrasound is the first investigation to be confirmed further by contrast-enhanced CT. EUS not only helps in the better characterization of lymph nodes, but also helps in tissue acquisition, which is a paramount thing for the proper management. In this era of availability of high-end USG, MDCT and endoscopic ultrasound, empirical treatment of abdominal lymph nodes with ATT, corticosteroid, or any other drug should not be done. Thank you very much for your patient hearing. I hope, Sanjay, I have finished in time.